Great, thanks, Rick. Welcome, everyone. I'm Tim Delaney, President CEO, as Rick said, of the National Council of Nonprofits. We're the largest network of charitable nonprofits in the country. And on behalf of our network, I'm delighted to welcome you all today to today's special event on how every nonprofit can help the communities we serve get vaccinated. You may have heard about today's webinar and the other one we're hosting this Friday from your State Association of Nonprofits. If you aren't already a member, please join your local state association. We encourage you to become a member of it today so you don't miss out on important information you need to serve the communities around you. I'll have more to share later about our second webinar that we're hosting this Friday on returning from remote work to in-person operations. But first, I want to thank you as nonprofits for all that you've been doing this past year. You've stepped up, you've stepped forward in a very challenging year to serve your communities with amazing dedication, leadership, and creativity. Since the Great Recession, more than a decade ago, the demands on nonprofits have been increasing, and unfortunately, revenues often did not. In fact, sometimes revenues were going in the other direction. So when COVID hit, many of us were already struggling to meet our missions. Yet when America desperately needed us, you, nonprofits, yet again rose to the challenges. Time and time again, you pushed forward, innovating ways to take care of people in local communities. Thank you for what you've been doing. But we're not done yet. America is calling out for our help yet again, this time to defeat the pandemic. We as nonprofits have a special role to play. The people we serve know us. They trust us. We need to break down those barriers to get them all vaccinated before new variants drag us all down backwards. Whether you connect 5 people or 500 people with vaccines, you can make a big difference in helping to end this pandemic. So to help us help others, we're thrilled to welcome an amazing lineup of speakers today. The first is renowned medical expert, Dr. Vin Gupta. As a Harvard-trained lung specialist, Vin has spent the past 15 years working worldwide to improve public health for organizations, including the U.S. Centers for Disease Control, the Institute for Health Metrics and Evaluation, the Harvard Global Health Institute, the World Health Organization, and the Pentagon Center for Global Health Engagement. Now, given this great diversity of experiences, he is now a trusted advisor and contributor to national and international media outlets on several of the most important health issues today, including serving as a regular healthcare policy analyst for NBC News and a contributor to the New York Times and CNN News Today. And I was just telling him briefly beforehand, he's a frequent visitor in my home because I get to watch him on TV all the time. So, Dr. Gupta, thank you for joining us. Please give us some advice.
Tim, thank you for the invitation to be here today and to be with my fellow distinguished panelists and for the opportunity to go first. So I thank you. It's really an honor. I did want to share some slides since I tend to, I learn best when I'm looking at things. And so I'd like to draw everyone's attention here for the next, say, 10 minutes, Tim, if that's okay, to this set of slides. And then if there is time, I'm happy to take questions, but I want to take away from the comments and time of my other panelists. I think, you know, being in this space right now, as a clinician caring for patients, I was just actually in Tucson in an intensive care unit last week, caring for younger patients that were, I'd say the median age of my intensive care unit of about 13 individuals was 40, which was drastically different from what an intensive care unit looked like 12 months ago, where it was generally individuals 60 and older. So the makeup of who's ending up in the hospital is changing. And I think that's allowed me, when I do have platforms to talk to people about the vaccine, it's allowed me to really lean into storytelling and to data in ways that I think hopefully are resonant and effective, because there's a lot of confusion out there about the vaccines, certainly about what different percent efficacy numbers really mean, and what about these side effects, and does the risk benefit really warrant vaccination, especially if you're younger and you think you're you're invincible. So I'll talk about a few strategies I've used just by going through some high-level data, and then afterwards, I'm happy just to connect offline with anybody if we don't have enough time to talk about specific questions here. So I'll provide my email in the chat. But first and foremost, I wanted to raise awareness on what's happening in the present day. So just talking about the landscape of the pandemic as it is today. COVID-19 remains the leading cause of death in this country. It's astonishing what we have, I think, at least myself, I'll speak for myself, gotten used to. But the numbers, the death toll stateside in places like Brazil and India, I mean, there is week over week, they're astonishing. We're losing tens of thousands of our fellow American citizens to this virus every week. I mean, it used to be as high as 30 to 40,000 week over week in the months of January and into early February. Now it's tapering off a bit, thankfully, but it's still the leading cause of death. I think that has gotten lost on a lot of us in the public domain, at least, because we're so focused appropriately on vaccination, but this notion that maybe we're through the worst of it, we're not. We're still very much in this crisis. But how do you make this real for, and let me increase the size of my screen there, apologies. How do you make this real for a population where in some cases, I'm sitting here in Washington State, less than 10% of the population has been actually infected with the virus, versus say New York State, where greater than 30% of the population we think has been infected with COVID-19. So there's been variability based on where you're sitting in the country in terms of how this virus may have affected you, in terms of your individual health or the health of your loved ones. Obviously, we've been all impacted in some way by the pandemic. But I thought this was really an important slide to show, because if it is true that you only need one dose of the Pfizer and Moderna vaccine if you've been previously a survivor of this virus, then that has serious policy implications in terms of how fast we could roll out the vaccine to more Americans. Potentially redirect supply from places that have had high rates of COVID survivorship to zip codes that are currently going through what we think is a mini fourth surge, like Michigan, for example. This notion that should we be trying to vaccinate places that have high amounts of variants, which I think makes some sense. But again, there's policy implications to a slide like this. That one, I think places that have experienced more burden, you're likely to see less hesitancy, or whatever word we're describing, lack of confidence in the vaccine. And then two, maybe that there is true scientific implications on how many vaccines individuals may need to receive if they've previously been infected and have survived this virus. Since we're talking about how nonprofits can really help scale willingness to receive the vaccine and then the ability to actually receive the vaccine. So there's a lot there. I thought this was important. This is data that IHME, the Institute for Health Metrics and Evaluation, collects in partnership with Facebook and other publicly available surveys on social media platforms, you name it. And there's a lot of variability, again, on the degree to which people that are eligible or will soon to be eligible for the vaccine, the degree to which they want to receive it. And in some ways, you're seeing a coastal bias here, where the states on the coast, there's generally speaking higher rates of vaccine confidence than states in the Midwest and the Heartland. I'm from Ohio, and so I've noticed some of the similar things just from family and friends, just hearing their concerns, their thoughts about the vaccine itself and what causes them some pause. And this is the big challenge of our times. I'm going to show you just a little bit forecast for when we're expecting this pandemic to end, and it all, frankly, is contingent on us addressing this problem: vaccine demand for the vaccine. Because soon we're going to have enough supply. Soon there's going to be enough appointments available. Can we get enough people vaccinated quickly enough so we can have some degree of normalcy, hopefully by the end of June, if not even earlier. This is what we're expecting to see in terms of uptake of the vaccine. So hopefully hitting about 70% if we have a continued rapid rollout, 3 to 4 million shots a day in arms, which is what we're getting at right now. That's rapid rollout. That's that top line hitting about 70% uptake of the vaccine by the end of June 2021, where that is fully vaccinated Americans, 2 doses. If you're in line for the 2-dose shot regimen, 2 weeks out, we're expecting hopefully 70%, if not more, Americans will have reached that benchmark by that time frame. But this is the message that I try to carry, in addition to a few others that I'll touch on momentarily. But this is, I think, a really important slide for all of us to be talking about. That what we're seeing in Italy, what we're seeing in France, Brazil, Canada, and India, places like India, is an out of control pandemic, in part because there's not enough vaccine supply in some of these countries, or in some cases, vaccine rollout has just been chaotic. But we're seeing chaos, lockdowns in places that, frankly, I'm astonished to see. Our friends in France, for example, they have a top-notch healthcare system. Germany is experiencing one of the worst outbreaks right now per capita, and which is also stunning because they had control of the pandemic just a few months ago. So the variants are real, and bad public policy combined with variants that we know are potentially more transmissible, like the B117 variant first identified in the United Kingdom, combined with the fact that we're seeing, just frankly, bad public policy being adopted by governors in select states, removal of mask mandates, 100% capacity in indoor baseball stadiums, things that just don't make sense right now in this moment. That could result in a pandemic that continues apace well into the summer. That's that pink line. And that's what we're forecasting is unlikely, but certainly possible. The green line is what we hope will happen. Continued rapid rollout of the vaccine, continued vigilance on the part of most Americans, we hope, where you're still wearing a mask, where you're still avoiding unnecessary travel, where you're still distancing, all the things that we've been talking about. If that can continue to the end of June, vital. And I think, and the reason I bring this slide up is I think this is vitally important to be messaging on to those who might be skeptical of the vaccine, that our progress right now is real as a country, but it's tenuous and it's easily reversible. We need to provide carrots to people more than just saying it's the vaccine will keep you out of the intensive care, because a lot of people don't think that they're vulnerable to the worst impacts of this virus. So how do we reach them then? It's, well, you need the vaccine, because if you don't get the vaccine, we're not going to hit normalcy. You're not going to be able to travel the way you want to travel. You're not going to be able to go out and dine with peace of mind. I have friends in Texas, for example, right now who are going out and dining, but they don't have peace of mind. I'll tell you that. And they certainly don't have freedom of movement to other parts of the world, other parts of the country where this virus still doesn't restrict them in some ways. So those are really vital messages in my mind. This is just to show you how cases are also, so, we talk so much about the daily caseload, and I sometimes on TV, I find it maddening that we do this daily case tracker as though that, I think that causes a lot of anxiety. I don't know if looking at daily cases actually means anything anymore, because people are not taking up testing nearly as much because they're getting vaccinated. I wonder how useful following day-to-day cases is versus day-to-day hospitalizations and deaths. You're going to find that the latter is the way people are going to start to define normalcy more and more, not daily caseloads. But this is what we're estimating, that there is a good scenario, that green line, that we hope number of daily detected cases really starts to nadir down to 0 or close to 0 by end of June. But there's that worst case event, a scenario where we easily could reverse the progress that we have right now and still see untold high numbers of cases well into the summer. And that would be devastating. I just shared this to show you that we're not making things up over at the University of Washington, that in general, our model and forecasts tend to align with most of the leading forecasts across the world. And I hate to say it, but most of these forecasts have been spot on when it comes to modeling out the trajectory of this pandemic, meaning high death burdens that were predicted well, early on in the course of the pandemic have, if anything, been exceeded. So these forecasts, in my view, are to be taken very seriously, especially the worst case scenario, and the likelihood of that potentially happening if we don't do all the things we should be doing. I'm going to skip this just in the interest of time, but kind of move into a few closing remarks, and then if there's time for questions. This is what I've wrestled with in at least the public domain, trying to bring a clear message on platforms to encourage people to get the vaccine when they're eligible, and to do so as quickly as possible. And I think message number one has to be these vaccines, whether it's the AstraZeneca vaccine, which, gosh, I feel like every other week there's some bad news about that vaccine, including this morning, or Pfizer, Moderna, Johnson & Johnson. Let's focus on the 3 vaccines that have been approved for use in the United States. All those vaccines, to the tune of 100%, keep you out of the hospital and keep you out of intensive care. Everybody that received any of those 3 vaccines in their phase 3 trial, all the recipients of the actual vaccine stayed out of the hospital. So even if they had body aches or sniffles from COVID, they were kept out of the hospital. They were kept from having lungs that look like this, the lungs on the right here, which is actual set of CT scans that have been optimized. The view has been gone through has gone through an optimization. This is not typically what you see in the hospital, but I think it drives home the point that vaccines are meant to keep you out of the hospital and prevent severe pneumonia, and that's exactly what they all do, to the tune of 100%, very well. And we've lost that message, I think, because now people are litigating numbers and percent efficacy that includes both averting not only severe pneumonia, but sniffles, which is, I never understood it. I'll see the New York Times, not to call out any media outlets, but put out big headlines. Johnson & Johnson vaccine is 70% effective against COVID-19. And that's wrong. That's the wrong number to cite. We should be saying it's 100% effective in keeping you out of the hospital. When they're saying 70%, that's averting any type of illness, meaning mild, moderate, or severe. But I don't know about you. I'd take a vaccine to prevent sniffles. And so I think we've lost the message and we've lost that clarity. And that's why there's been this ability for bad actors in the public domain to seize on that lack of clarity and to cause confusion, and to in my view, to allow anti-vax conspiracy theory type rhetoric to unfortunately gain a lot of ground and gain a lot of traction. So I'm hoping we can seize that narrative back about and crispness and clarity on why you get the vaccine and why these vaccines are so good. So that's number one, building vaccine confidence. I think we need to be aligned on why do we get the vaccine in the first place, and message on that clearly. Number two, and this harkens back to what I was talking about earlier when these forecasts, the vaccine will allow for normalcy only if we all get it. And so even if people feel like they are protected from the worst, if they're invincible from COVID, you're still going to feel friction if you don't get the vaccine, if enough of us don't get the vaccine, because then we're still talking about restrictions on normal life. And some people just want to go back to normal life. And the quickest way there is through a vaccine. So I think leaning into that. Number three, I'll say, I just came back from Arizona, where I was caring for individuals in their 30s with rare complications from this virus. One complication is called Guillain-Barré, which is full body paralysis that can sometimes happen as a result of an infection, viral or bacterial. And I message on that. I drive that home that, you know what, it's a rare complication, but this virus is unpredictable and it can impact you and it can impact others that are young. Why take the risk? And so leaning in on storytelling, I think we've underutilized that. So again, another strategy as we're talking about building confidence across all demographics. I touched on a few other elements here that probably for a later moment, but I've wrestled with why we didn't more intentionally account for race and other demographic characteristics up front in the priority distribution of the vaccine. When we talk so endlessly about COVID exerting disproportional impacts on Black and brown communities, well, why didn't we then account for that when we distributed the vaccines in the first place? back in January. And I think that actually helped, that eroded some degree of trust. Here we're recognizing a problem, but we're not doing, well, we're not prescribing the correct solution here, which would be to account for race to some degree. And then I'll close on this. I know I'm taking up way more time than I promised here. School reopenings, top of mind for all the parents out there. I gotten involved in this kerfuffle a bit, a little unintentionally, but in my view, and I've helped organizations try to stay safe and healthy, it is really hard to do mitigation well, whether it's ventilation, starting testing, you name it, all the things the CDC has put out there for public school districts especially. It's hard to do that well. The easiest way to keep the most vulnerable healthy in what is going to be a really difficult environment, school-based environment, where transmission will happen, is just to vaccinate those that are at highest risk and do so quickly. That's happening now, but again, just the nature of the ways in which our policy debates have evolved and transformed just in the last few months. I've taken up way too much time. Thank you so much for the invitation. I'm happy to take questions if there's time. Otherwise, I'll put my email in the chat.
Thanks, Vin. We really, really appreciate your wisdom and your insights. I know that Melissa in the White House needs to get going. So if you could share your contact in the chat, then we'll have people send their questions straight to you. Thank you. Thank you very much. It's been truly terrific. All right, Melissa, we're now going to hear from Melissa Rogers. She's the Executive Director of the White House Office of Faith-Based and Neighborhood Partnerships. But that's not all. She's also the Senior Director for Faith and Public Policy within the Domestic Policy Council. Melissa has previously served in the Obama administration. She's been a visiting professor at Wake Forest University School of Divinity, as Executive Director of the Pew Forum on Religion and Public Life, as General Counsel of the Baptist Joint Committee on Public Affairs, and as Nonprofit Senior Fellow at the Brookings Institution. She's a graduate of Baylor University, national champions in men's basketball, and University of Pennsylvania Law School. Melissa, I'll toss it over to you now. Thank you for joining us.
Thank you. Thank you so much, Tim. It's great to be with you all today, and hello to everyone. It's great to be able to join this call. And my apologies, I've got a 3:30 meeting, so I'm just here for a couple minutes, but I wanted to extend my thanks to the council for all the work that you and the members do to serve people across the country and around the world. We are very much indebted to you, and know that over the past year in particular, you've done backflips to try to help people keep life and limb together as well as their livelihoods. And we couldn't be more grateful. And on behalf of the president and vice president, we want to not only thank you, but say we're trying to work toward a situation where there will be more help for the mission that you carry out each and every day. And we're happy to talk more about that. And what I'll do after the call or after my time on the call is send a bunch of resources to Tim and his staff so that they can be shared with you. Just to piggyback on the earlier comments about COVID-19, I also want to thank you particularly for your involvement in this issue. Just yesterday, I was with the president as he toured a pop-up vaccination clinic that was at Virginia Theological Seminary. And it's a great partnership of faith-based organizations, community-based organizations, including a neighborhood health organization that supplies the vaccine to the partners and helps to staff the pop-up clinics, and also support for the federal government in different ways. And it's just such a wonderful thing to see America at its finest, where you have people of different backgrounds and beliefs working together across many differences to try to make sure that more people get vaccinated. And as you know, now we have increasing supply of the vaccine, as well as the increasing eligibility for the vaccine. And so very soon we're going to be in a situation where we need to have all hands on deck as we seek to get more people in the United States vaccinated. So we certainly welcome the help of all nonprofit partners in this work. And what I'll do, again, after I have to leave the call, I will send information to Tim and his staff about guides from the CDC on what you can do, how you can participate, and also some other information about how you can actually serve your institution, may be able to serve as a vaccination clinic, one of these pop-up clinics, if you will. And the key toward that, if you're interested, is dealing with state and local authorities, including your local public health board, which is going to be very instrumental. It is something that happens state by state and locality by locality. So we welcome you to get in contact with them and to see how you can partner with them. Even if you don't want to serve as a clinic or you can't, there are ways to share information that will be relevant to your community. And I will send a CDC guide that talks about different ways to do that. Also, there are several grant programs that have come online, mostly to funding for states and localities, but also with provisions for them to be able to work with non-governmental partners on encouraging vaccination and increasing vaccination of Americans. So I'll send that information along too, so that you'll have it. And with apologies for only having such a short time with you today, I just want to end where I began. Thank you for your work. We're looking forward to forging, closer partnerships with all of you. And we thank you very much for your time today and for the continuing conversation and collaboration.
Melissa, will the materials that you send include how people can sign up to be in the community core?
Yes, definitely. And I'm so glad you mentioned it, Tim. We have formed this COVID community core, which includes, and we'd love to have all of you join. That is, and I know the council has already joined, thank you very much. And we are working with those members to share information like the kind I just discussed, as well as social media messages that you can share, as well as a kind of program called Share the Mic, where you can turn over your social media channels to a doctor or somebody else from the medical profession to be able to share information with people who may be confused about the vaccine or anxious about the vaccine or fearful. So this is a program that we hope all of you will consider, and we'll send up follow-up materials so that everybody can join if they wish, and we'd certainly love to have you.
Great, thanks, Melissa. And nonprofits, you all know that we must remain nonpartisan. And I actually put in the plug here because this is nonpartisan. It doesn't have anything to do with partisanship. This is about getting information for us to use and distribute out to our communities so that America can be healthier and we can put this pandemic behind us. Melissa,
Absolutely.
I know that
Thank
you've got to
you,
run. Thank you for making the time for us and joining us today.
Thank you so much,
Be well.
Tim, and thanks everyone.
Great. And one of the items that came into what I was referring to as the chat box, it's actually the question box. There is no separate chat box that I'm seeing, so you need not worry about that. Now we get to really the heart of this program for nonprofits. Now we get to hear from 3 inspirational nonprofit leaders from across the country who've been helping connect people in their communities with vaccines. We're hoping that hearing from this illustrious group will leave you feeling inspired to do all that you can to help the people you serve get the COVID vaccine. And we hope you will also see that you don't need to be a huge organization or to have a healthcare related mission to be part of perhaps the most important global effort of our generation. I'm going to start by asking Astrid Aveledo to join us. She is the Executive Director for the Dispute Resolution Center of Grays Harbor and Pacific Counties in Washington State. She's also one of the founding members of the Grays Harbor Rise Coalition. For the past 2 decades, informed by her Latinx and tribal roots in the Pacific Northwest, she has devoted her career to the nonprofit and tribal public sectors with a highly attuned instinct for partnership development and coalition building. Astrid, can you help guide the way for us?
Thank you for having me here. Very honored to be representing the Grays Harbor Rise Coalition today. Prior to COVID, my partners and I all had at least a general awareness of the folks in our community that we're working to serve our Spanish-speaking community members. Our focus on information equity during COVID brought us to work together closer than we ever had before. In our case, it birthed a coalition, which is now a permanent asset for our community. I think it's important to share some of the early lessons learned that became foundational pieces of how we go about our work. First, an acknowledgement that we each spoke to a very different part of the Latinx community. No organization could claim to reach the entire Latinx community in our area. Even in our faith, we were not served by one church. Our community members actually belong to a few different faith traditions. This made collaboration a very obvious choice. We all played a part in reaching our community, and united, we expanded our reach. So we made a commitment very early on for each of us to use our own channels, and sometimes that included our personal channels in support of the efforts of the coalition so that we could maximize our reach. Second, we understood we were trust brokers. Our community knew us and had come to trust us, and we took that responsibility very seriously. We also recognized that that alone was an asset. For us, it meant we needed to be incredibly well-informed, and it also highlighted how what we do, more than what we say, would communicate things to our community. So we're not only learning and informing our community, but we understand that whether we intended to or not, we modeled behaviors. Third, we understood that the message needed to be adapted to the community, but interpreters alone were not enough. We had to shine a light on the pieces that were of special concern to us, or that affected us in ways that it did not affect the rest of the community in the same way. A Latin multi-generational home, for instance, is a very integrated household. We don't just live under one roof. All of our needs are highly integrated. Fourth, like all of us here, we had to adapt from in-person interaction to physically distanced models. But technology is not prevalently used in our Spanish-speaking community. That was only made harder because of the challenges related to internet access in rural communities. As a group, we talked about the importance of informal channels, how our clients won't dial official lines until they absolutely have to, but they will text us on our personal cells. So a first name and a number they can text goes a really long way. Some of us also had success reaching folks via Facebook Lives. Generally, what we found is that things people could access through a mobile device seemed effective. And the last one is more of a description of the way that we work together that I think has important implications on our work. We do not have formally defined titles or roles or a hierarchy in our coalition. It is very much a shared leadership model. Anyone from the Latinx community that has a role in supporting our community, whether that's as a volunteer or a staff person in some agency, they're welcome to come to our meetings. And we all feel at once supported by each other and that we have a role to play in keeping the work of the coalition alive. In our meetings, everyone is encouraged to speak up. We have an agenda that we loosely follow because the burning questions or concerns from our community always take precedence over the agenda. This, together with the importance we have placed to learning in our meetings, means that in our space, curiosity is very much encouraged. We try not to make assumptions. And very much the community needs are the driver of every conversation. Concrete examples of our work have included the organization of high interest events, informational videos, and continued collaboration with public health. On the high interest events, we started organizing what internally we would refer to as super events. And essentially what that meant is that we would take an event one of us was doing and we would build upon it to make it more attractive to the community. So we would take a partner event like Catholic Community Services food distribution event, and through another one of our partners, we were able to secure diapers and baby wipes, which we had learned were a high interest need in our community. Then we had members who volunteered to pick up the donations and help at the event. And we could use an event like that to help us distribute information about COVID-19, distribute masks public health provided us, And we even at some point had a bilingual census worker that came down and helped people complete the census or answer their questions about the census. This became a very successful model for us, and it was one that we would continue to use. We also completed a few informational videos. Our first video was a conversation around how to prevent the spread of COVID-19. We would go on to produce 3 more videos, one on the safety of the vaccines, the other on the phases and availability of the vaccine, and another one on the variants of COVID-19, which was a hot topic back when we were making these videos. When we produce a video, it really is important to us that first, of course, the information needs to be accurate. It is also important that they see faces from their own community. Also important to us is that aside from the science, that we're also talking and speaking to the human aspects, that we give a face, for instance, to the pain of having to cancel a milestone family event, or the risk and needs of our elderly abuelita versus the 15-year-old in the home. And finally, it's also important to us that in our words, in our questions, in the topics we address, that they see that our community sees itself reflected. Finally, we continue to collaborate with public health, providing them information and insights. At Grace Harbor, we have a fairly young Latinx population. As stages open up and working class folks become eligible for the vaccine, we see more Latinx community members getting vaccinated. That alone can help get the word out and inspire more people to get the vaccine. More concretely, members have also been consulted with by public health as it plans to roll out to certain groups that recently became eligible. Thank you for having us here today to share, and we are very honored to play a part in bridging public policy and community. Thank you.
Now I'd like to turn things over to our friend Vanessa Fields. As a community advocate in the nonprofit sector with over 15 years of experience in rural areas supporting underserved, underrepresented, and low-income populations, Vanessa's overall goal has been to actively assist individuals, families, and communities in creating opportunities that will promote and influence their recognition of their most needed resources, particularly those related to their health and well-being. As director of the Southeastern Halifax Coalition in North Carolina, she leads the organization's focus on building healthy, sustainable communities in rural, impoverished, underserved areas that are experiencing limited resources and insufficient accessibilities to healthy choices of food, recreation, medical services, transportation, and more. Vanessa, turn things over to you now.
Thank you, Tim. Good afternoon. My name is Vanessa Fields, and I'm director of the Southeastern Halifax Coalition, which is located in Halifax County, North Carolina. We are a community-based network of nonprofits, organizations, and individuals that work collectively together to build healthy, sustainable communities, particularly in underserved and underrepresented areas with limited resources. Through effective implementations, we engage these communities in our efforts to make needed resources available and accessible that will help improve their overall healthy living outcomes. Our network has the capacity to offer an array of services through collaborations with our health department, medical service organizations, legal services, local municipalities, faith-based organizations, social, community, and nonprofit organizations, and individuals who are key people in their communities. The COVID pandemic presented changes having to go from face-to-face meetings to Zoom and virtual everything. But nevertheless, we kept moving and maintaining momentum as we wore our masks and distributed masks throughout the county, practiced social distancing, and washed our hands. The challenges of transportation, education, information, registration, and communication were present all during the census, during voting, during COVID testing, and now also present during COVID vaccinations. Our networks distributed care packages during these events that included educational information, gloves, sanitizer, masks, pens, etc. COVID vaccinations are receiving greater attention because of the health impact that it has on our lives. and the thoughts of those who are no longer with us. Some reasons given for not wanting to take the COVID vaccinations are underlying health issues. They believe the shot will give you COVID or the flu or the pneumonia. Males feel that it would affect some of their hormones. There is a fear in the community. And also there are limited resources to pay someone to take them to get the shot. Online registration has been challenging for COVID vaccinations, usually hard to navigate to get a scheduled time without some assistance. Also, scheduling to get back to that second shot was even harder. Many not rescheduling, but just walking in knowing that they had a date for their second shot. And even then, some still did not get their second shot at that time. For these reasons and others, we are concentrating efforts of increasing accessibility by setting up vaccination sites that are in close proximity of where individuals live, such as at churches, in community rooms of housing complexes, at community centers, and at local municipalities. We are especially targeting the in-home, the disabled, homebound, homeless, senior villages and housing subdivisions, and any unreached populations, actively promoting them to get their shot. Establishing relationships and building trust in poverty-stricken, low-income, underserved communities is important and inclusive in our services. We reach out to our communities knowing that everybody is somebody, giving respect to get respect, smiling as we speak to everyone we greet, and our first impression should be our lasting impression. In order for our people to be receptive to our services, we meet the people where they are, recognizing that our people matter more than any money or any profit. Through education and information, they now realize that they have choices and options and become equipped to make better decisions. They are empowered from the information and education received virtually through Zoom, social media, flyers, outdoor canvassing, radio, and TV ads. For our minority population, particularly, a more caring approach is more effective, one that presents a feeling of equity, not charity, a feeling of justice and equality and not being targeted. We get healthy together by getting everyone involved. When we feel better, we do better. When we gain trust, everybody wins. The greatest reward being a community advocate and witnessing our people get the help and resources that are necessary for their health and well-being. The community is our family. We care for our family, we care for our community. I'm giving a reference to a gentleman in his 80s, living in a senior village, and he is a one-leg amputee and he is in a scooter. And I was visiting the village simply to see who needed their shots done. He was sitting in his door waving as we passed by. So the property manager and I approached him and to ask him if he had had his shots. And he immediately said, no, I haven't, but it's only because I cannot figure out where and who and where to go or how to get it done. So immediately I asked him, if we can bring the shot to you here on the premises on site, would you be willing to take the shot? He said, yes, ma'am, I certainly will. I will scoot right on over to the site. So we just have to meet the people where they are. And he was waiting for someone to come to him because of his conditions. He was willing, but no one had approached him. He's ready right now to take his shot. So in our goal to build healthy communities, we will continue our collaborations and efforts to help improve our health outcomes by promoting COVID awareness and hoping to bring this pandemic to an end simply by wearing our masks, continuous washing of hands, practicing social distancing, and encouraging our communities to get their COVID vaccinations. We thank you for allowing us this time, and it's a pleasure being on this panel today. Thank you.
Thank you, Vanessa. Terrific. Folks, I told you that we were going to have some inspiration, and our first two panelists have delivered and knocked it out of the park. Annie, it's going to be up to you now to close out. We're now delighted to welcome Anni Chung, who served as the CEO of Self-Help for the Elderly since 1981. Self-Help for the Elderly is a 55-year-old community-based organization which provides a comprehensive range of elder care in San Francisco, San Mateo, Santa Clara, Alameda, and Contra Costa counties. Self-help for the elderly serves approximately 40,000 mostly Asian, immigrant, low-income seniors. During the COVID pandemic, they organized home-delivered meals to over 5,000 seniors each day. When the standing room only buildings in Chinatown experienced breakouts in COVID cases, their social services staff conducted outreach to these residents and passed out PPP and other educational materials to keep them safe. Annie, the floor is yours.
Thank you very much, Tim. And thank you, Rick. And a shout out to Jen, if Jen is joined us today from CAN in California, our California Association for Nonprofit. Thank you for inviting me to this wonderful panel. I felt that after Astrid and Vanessa spoke, they have already given, part of my remarks because we're very similar, probably in nature. Our clients really are the center of our universe. And, like when COVID happened and the shelter in place happened last March, we know that our clients, particularly our frail seniors, are going to depend on us to respond very quickly in order for them to survive this pandemic. There was a lot of fear. Immediately, they couldn't come out to our senior centers and our meal sites. And that's why when Tim introduced me, we have to almost drop everything and to create a home delivery program that utilize almost 400 volunteer drivers in order to drive the meals to the elderly. Exactly what Vanessa said. If they cannot come out for their services or their meals, we have to bring it to them. So very similarly, Tim and Rick and others that joined us today for the vaccine rollout, back in late December and January, we already heard that vaccines are going to be starting to be available, right? But almost immediately, because we have the experience to serve a very monolingual and low-tech kind of a senior community, we know that anything online, anything that required English, right, to sign up for a vaccination appointment just would not work with our clients. So starting in January, we went to every elected official, our mayor, our supervisors, our directors, and our liaison officers at the Department of Health, letting them know that everything they do have to be bilingual, bicultural, in language, but also while there are lots of information materials that are in language, we went to every one of the vaccination appointment site back in January, February, and all of them were in English. So we knew that unless our seniors have relatives or family members that could help them get the appointment, we just have to find another way to get the vaccines to the elderly where they are. So we convinced the Department of Health to let us collaborate with our Asian physicians group called the AAMG, the All American Medical Group. And our community doctors are all bilingual doctors. And instead of having our seniors travel cross town to these massive vaccination sites that they easily get lost, then our doctors would bring the vaccines and come to our senior centers, just like Vanessa said, and our meal sites, where our elderly are coming every day already to get their meals. And right then and there, right in the comfort of a familiar setting, our community doctors were inoculating literally thousands of our elderly. And you see the big smiles on their faces because the doctors talk to them in their language. And when they need a glass of warm water or tea, we give it to them. Some of them are hungry. We give them breakfast and barbecue pork buns, and they leave kind of feeling good, even though they said their arms are a little sore. So having that effect on other elderly who are less enthusiastic to get the vaccines, but then they started to see their friends, right? People that they hang out with every day getting the vaccines. And that, I think, the peer-to-peer kind of effect happens a lot. And elderly that are more hesitant to get the vaccines are now coming back and say, I want to sign up for your next vaccine day. So that really works, you know, when elderly talk to their own friends and people that they know. Also, because we are the go-to community hubs, right? When anything our seniors need, the first group that they think of getting assistance are really us, Astrid's group, Coalition, and Vanessa's group. So we know that when we started to hear that the children are the ones that are calling their parents to ask them not to do the vaccines, then we said, uh-oh, you know, like they are not making the decision. So we have to find a way to get to the children and explain to them and answer all their concerns and questions, right, about the vaccines or the misinformation that they were getting in order for them to convince their parents, you know, now it is safe, you know, or it is better for you to get the vaccine. We also utilized a very successful Chinese WeChat platform, which is a social media that almost all Chinese speaking people in the United States use to communicate with their loved ones in China, Hong Kong, Taiwan, you know, and the WeChat is very successful to help us post a lot of the frequently asked questions, the side effects, the benefits, you know, of why they need to be vaccinated on this WeChat site. And then we create a lot of conversations with our seniors so that they could ask the questions and we could answer them or send them some materials that they could read in language again, so that their confidence builds up. Also, I would recommend that nonprofits could also collaborate with other nonprofits in your community. So there are 4 of us that collaborated a couple months ago and created a vaccine rolled out response plan. And we got, you know, funding from a local foundation to do special outreach. So we could tailor our outreach to families, to the youth, to the elderly, and to the people who are living in the very overcrowded housing conditions in Chinatown. About a month ago, Chinatown neighborhood was the lowest in terms of the vaccination rate. And when we heard that statistic, we say, uh-oh, you know, that just won't work. So all of us collaborated in the community and created a site where we could answer all the questions, you know, in language, tell them where all the vaccination sites are that don't need even prior appointments, or agencies that could help them get the appointments or sign them up when we have pop-up vaccination days. So all this seems to be extra work, but we're very willing and ready to do it. And one thing nonprofits have is a very extensive volunteer network. So go out to your network, get volunteers to help you with registration, you know, crowd control, providing whatever support like rides to the vaccination site. And if we could do that, I think we actually saw the 50% vaccination rate for a certain zip code in Chinatown, almost, you know, within the last 2 weeks, kind of an increase. So I think all those, and I think Vanessa or Astrid already mentioned it, utilize your ethnic media or your media friends so that they could also publicize, right, where the vaccines are, where you could get help, and the benefits of being vaccinated. I think all these are proven community-based techniques of outreach that proven to work. The 3 panelists that spoke, you know, all are bridges between the resources and the people that we serve. So if we play this role every day diligently, I think that San Francisco just reached a milestone. Over 84% of older adults in San Francisco already got their first dose. So we're hopeful that we will reach Dr. Gupta's goal of 70% very soon. 64% had also the second dose already. So 6 more percentage points and we reached the 70% goal. So I'll stop right here. Thank you very much for inviting us and good luck to all of you. And if you have any questions, you could reach out us or email us. Thank you. Yeah. Thank you, Tim.
Annie, people can knock it out of the park, and then you can build a whole brand new park, and you just did. Fantastic. What I am just so inspired by these three speakers, in part because what they've been doing is modeling everyday advocacy. It isn't a matter of going out and talking to a member of Congress to pass this law or that law. It's about caring about your fellow human beings. And these people have demonstrated how they're caring, and they're using the leader's most powerful tool, which is their ears. They're listening to their community needs. They're then using some foresight to try to solve the problems. It's just astonishing what you all are doing day in and day out. I would like to go on for another 2 or 3 hours because we've just scratched the surface. But unfortunately, we asked people to commit an hour, and we have now reached that time limit. So what I want to do is just to review a couple of quick items for everybody. And in particular, as was mentioned earlier at the beginning of the webinar, we'll be sending out to everybody tomorrow a link to this recording so that you have this information at your fingertips or your visual contacts so that you can review it and continue to learn from your colleagues. We will also be sharing in that resources that were discussed today, the materials from the White House as well as other places. We hope that when you receive that, if you haven't already, then register for the special webinar that we're doing Friday about how we can be helping serve not just our communities, but as we've been doing through our hearts, as demonstrated today, but also through our heads. How do we most help people? We help the helpers. And that means our employees and our volunteers, making sure that when they return from remote work to on-site work together, that they are safe and that we can all be working together. So one of the main questions, for example, that came up about how we can be helping nonprofits return from remote to in-person is, can staff be required to be vaccinated? Well, we all might have different opinions, but why don't we hear from some experts? We've aligned those experts up for Friday. So we'll be reviewing that question and others. Again, please join me in thanking our speakers today, to everyone for joining us today. Let's all go out and get more shots in arms and go out and get more masks up so that we collectively as a community can be leaders demonstrating the way, but also helping the communities that we all serve. Again, to Astrid, to Vanessa, and to Annie, you are today's heroes. Thank you for what you do day in and day out. It's been a privilege. Thank you.
Thank you. Thank you, everyone.